takes me great pleasure in introducing Krish Menon, who is a friend and colleague from the UK, and he's officially the leader of our gang in the UK as the president of the British Transplant Society. Welcome to my home city, Krish, and looking forward to your talk.
Thank you very much. I think at the outset, I'd like to thank Ramdeep. First, I'll thank him, and then I'll not thank him. So the thank you is for inviting us to Kolkata for this wonderful meeting, and the no thank you is for the topic he has chosen. As Sonal said, it made me think a little bit because it's not a topic that is normal. So what I had to think about is, what is Ramdeep wanting me to do? And I haven't phoned him to find out. I just put my perspective onto it. So it's lessons learned from transplant surgery for colorectal liver metastases. And I think when you look at surgery for colorectal liver metastases, what has changed is extending the limits of resection. When we started off doing smaller resections, we extend our resections. And then we started to combine transplant techniques to resect metastases that were in difficult locations. And by that I mean, I will illustrate some of these where the tumors are close to the inflow or the outflow. And then the final bit, which is liver transplant and resection for colorectal liver metastases, which is a new concept that's come up from Oslo. So we are all familiar with how we made liver surgery safe. And it was improvement with lowering CVP, selective use of minimal access techniques, and this is something that's new that's come about, using minimally invasive surgery. Ultrasonic dissection, already Sonal's touched upon, but more importantly, relevant to this talk is selective use of ischemia techniques. And most importantly, improvement of disease control by surgical advancements. So if you break it down and try and marry up transplant techniques and surgery for colorectal liver metastases, I think there are specific transferable skills from a transplant surgeon to a HPB surgeon dealing with colorectal liver metastases. One is extending the limits of resection. What a transplant surgeon will tend to do, he will be able to go a little bit step further than a HPB trained surgeon. And that's because they will be able to combine the hepatectomy with vascular resection, such as portal vein resection, hepatic arterial resection, and those anastomoses a transplant surgeon will definitely do better than a standalone HPB surgeon. The third bit is where the hepatectomy has to be done for colorectal mets, where the tumor is sitting near the confluence of the three veins on the inferior vena cava. That is really challenging. That requires vascular exclusion and specific ischemia techniques, and I'll go through some of these: ex vivo, anticitum, in situ hypothermic perfusion, and total vascular exclusion. One of the things I find as a transplant surgeon, we deal much better with the caudate lobe. We take out the liver so often, and the caudate lobe in isolation when you're doing it can be very challenging because you don't have any control proximally or distally, and you're trying to get the lobe out, and I'll go through the anatomical reasons why that is challenging. So when you talk about ischemia techniques, it's either you go for warm, where the liver is resected with an extended resection using warm techniques, or a cold ischemia, which is these four methods. What is it that we're talking about when we talk about clamping the cava? So you can see in the top left, you got the clamp of the cava on the top and the bottom, which means you have to go on to veno-venous bypass, and somebody mentioned this earlier. So you go on to systemic bypass, and then you can see the cannula in the portal vein. So you clamp the artery, cannulate the portal vein, go on to portal bypass. And then you can resect the tumor which is involving the cava. If you've got the tumor involving only the right vein, then what you can do is place your clamp tangentially, so you protect the outflow to the left side, and you can still do the resection. The other one is where you can do an inflow occlusion, go on to bypass after total exclusion, and do a patch reconstruction of the IVC. And the straightforward one is where you just place side binding clamp and resect part of the IVC. I must say, I had the fortune of working with this man, Peter Lodge, and I must pay tribute to him today because he was one of the brilliant innovators. At a time when we were thinking about making liver surgery safe in the 1990s, this man had taken it to a different level. And he used to say, I want to take out as much liver as possible till the last hepatocyte is clinging onto the IVC for its dear life. So all of what I'm going to talk today is what he started in the United Kingdom. So this is not a colorectal met, but just to show you an IVC resection where you actually use a Dacron graft for a large tumor after total vascular exclusion. In situ hypothermic perfusion is technically where, as I said, you go on to systemic bypass, you go on to portal bypass, and it's an exhalophyme bypass, and then you can clamp the cava, total exclusion, resect the tumor with the vein branches. And this is an example of a large tumor which has got the impingement of the left vein outflow, and that actually requires total vascular exclusion. Anti-cytum is an interesting technique where you actually have a tumor which is involving the confluence of the three veins. So you go on to bypass, but then you just divide the top cava, flip the liver backwards, and then you resect the tumor and then reimplant the cava. Now, these are things that I think a transplant surgeon only can do. And this is an example of large tumor, colorectal met, involving the three veins. And you can see here, when you get total vascular exclusion and an anti-cytum approach, you get very little bleeding, and you can take the tumor out with clear margins. Next comes the ex vivo, and this is a video, there's a video that I'm going to show you of the ex vivo resection. This is where, as a transplant surgeon, you actually take the whole liver out, where the tumor is involving the veins, and then you resect the tumor from the part of the vein that's involved, reconstruct on the bench, and put the liver back into the patient. And that, again, is really the extreme of transplantation. And this is just an example of how you do it. As you can see, the cava has been clamped, you're on portal bypass, you take the liver out, and you can use a Dacron graft for the left vein reconstruction. And I hope this video plays. And this just shows you the actual video of the operation for the ex vivo. So this is a colorectal liver metastasis. As you can see, the livers are very congested, so they bleed quite a lot. So you have to be really careful when you're taking the liver out. And once you've got the liver mobilized, we do an ultrasound to check the vein that is involved. As you can see here, that's the vein that's involved. And what we need to do is, when we explant the liver on the bench, we'll have to resect that part of the vein and create an orifice for the left vein, which is beyond the area of the involved tumor. And once you're happy with the ultrasound mapping, you start to dissect. As you can see, disconnect the inflow, which has been done now, and then you're ready to clamp the vein and the IVC and take the liver out. We are on systemic bypass and portal bypass. You'll see a video of that as well. So you can see now we're flushing the liver on the bench, get the blood out, and you can see that's the bit that's involved. And that's where you're going to try and do the resection. And this video, part of the video, will show you, hopefully, that we are now going on to portal bypass. And you just have to be careful here because you don't get air bubbles in there. So you go on to portal bypass, and once you're on portal bypass, that's the systemic bit, which you can see. And we got a perfusionist usually who does that. And then you map out your tumor resection line. And once you've done that, you can start doing the Coues ring to get the part of the tumor resected off the left vein. So again, because you're doing it on the bench, you can do it with a knife. You don't have to use a Coues there. And once you're in the bench, the other advantage is you get no blood loss. So it's a very clean resection with a Coues. And you can see here now, once you're Coues ring out, you go through very neatly with nothing that's going to impede your visualization, and get the tumor resected. And this is the last bit of the resection that's coming through now. And then the next bit will be, we prepare the cut surface and get ready for implantation. And again, you know, very comfortable to do this on the bench as a transplant surgeon, because as we do split livers, it's pretty much like doing very much of a similar thing. So that's the tumor that's been removed, and that's the orifice of the left vein, which is flush onto the, now sometimes you can use a patch, otherwise you can put it straight onto a Dacron outflow, which is being shown here. And it's much more stiffer, so it actually stays without being bent. So you get much better, much lesser problems with the outflow. And once you've done that, then what we do is, I mean, you may or may not do it, but we spray the cut surface as we do for our split liver transplants with, and we're checking for bile leaks here actually. And once you've done that, you stitch the bile leaks and then spray it with Co-Seal or Biogel, whatever you want to use to seal the cut surface. And that's just to minimize the problems when you reperfuse, because these livers are post-chemo, they're quite congested before, so they will bleed when you reperfuse them. So at this point, you have to spray and get as much hemostasis. I mean, I'm not sure how much this helps. Actually, meticulous hemostasis actually helps, and stitching the bile leaks. And now you're ready to implant it back in there, and you can see that the implantation is happening. I don't know what's happened there. The video is... Why has it stopped? Sorry.
Can you play the video, please?
Sorry, it's not playing again. about that. Let me see if I can take it. Wait. Can you move it there? Okay, we were here, isn't it? Right. So, right. Hopefully it plays. Doesn't freeze again. Oh, it's frozen again. Okay. I can't waste too much time. So I think basically what is done is once the outflow is done, the next bit is you reperfuse the liver and you have to do a rule loop onto the bile duct. So the main bits you've seen of how to do it. The next bit is isolated caudate lobectomy. This is really a challenging operation. And I'll tell you why. Because the caudate lobe, for those who understand anatomy well, there is a spigal lobe, there's a paracaval portion which is challenging, and there's a caudate process. So when you're doing an isolated caudate lobectomy, as a transplant surgeon, you're better doing it because you've got no control on the top or the bottom, and you're trying to resect it. And as you can see, the chordates sometimes, as Sonal showed in one of his videos, can be wrapped around the IVC, which makes it quite challenging. The other thing I would say is those who are interested in the caudate lobe should read this paper that came from Mohammed, where you actually can inject methylene blue and see that there are 3 separate supplies to the 3 parts of the caudate lobe, which is why there's a higher risk of bile leaks with this. Unfortunately, I don't have an open resection of this video. I just have a laparoscopic one, so that's how I've done it. I isolated for a colorectal liver met, and you can see that that's the metastases sitting in the IVC, and again, it's not playing. It's playing now. Okay. I'm going to try and fast forward this because Randeep is looking at me, so I think we will move on to the bit here. So this is the key bit where you're actually starting to mobilize the liver of the IVC, which is the caval portion, and you have to be flush on the cava. You've got no control on the top, no control on the bottom. This is the inflow of the caudate lobe being taken with a sling, and I use a retractor to retract the left liver up, and I do this operation in 3D, so it's very precise. There is no pass pointing, and you can hold up the inflow, take that inflow separately, and then after that you take the outflow separately. So I personally think that this part of the operation, if you are not a trained transplant surgeon, if you run into bleeding, you wouldn't be able to get the control very easily, particularly of the IVC. So I think that's the outflow now being taken of the caudate lobe, and you can see here, this is again flush onto the IVC, and you're trying to resect the caudate lobe in its entirety. So the paracaval portion sometimes goes around, and you may have to mobilize that a little bit more to try and get it all off completely. And I think once you've done this bit, the next bit is the final bit of the parenchymal transaction, which is done, and then you can actually proceed to removing the caudate lobe. And this is the last bit of the caudate lobe process being divided for finishing off the caudate lobectomy. And this shows you the completed operation where the caudate has completely been taken off the IVC, and that's the groove of the IVC that you can see on the specimen at the left-hand side. And then again, if you've got a bleeder, you can actually stitch it to get the hemostasis. Again, in this particular patient, what we do in laparoscopic surgery, reduce the pneumoperitoneum, so you see any venous bleeding. And there was a venous bleeder here, which we had to put a stitch on. And it's really important to do this, otherwise you will get into problems post-operatively. So this is again something, for me as a transplant surgeon with laparoscopic skills, I find it quite interesting to do. I won't bore you with how I tie the knot. The last bit is the rapid for colorectal liver metastases. This is a technique that was evolved from Oslo. And what you have is if patients got unresectable colorectal liver metastases, what they came up with is a rapid procedure where you sort of donors. So you use a left lateral segment. So phase 1 is you do the left hepatectomy and implant a left lateral graft, leaving the right lobe in situ. And phase 2 is you complete the right hepatectomy as you would do for an ALPS procedure. And this is just a couple of pictures to show you how it's done. And that's the implanted left lateral graft with the reconstruction of the left hepatic artery, left portal vein. And then what you do is you modify the inflow of the right vein so that you then don't get hyperperfusion of the left. So that allows for the regeneration to happen. And then you can proceed after that to taking out the right lobe. And again, this is just another example of a patient with an accessory artery. So the key points in rapid for colorectal metastases, which is an evolving technique, is liver transplantation is a valid option in selected patients. It is feasible with safe expansion of the donor pool, and living donor actually is quite favorable in terms of the rapid procedure, and the concept is still experimental surgery and should be done as part of trials only. So in summary, a liver transplant surgeon, I think, in my opinion, has unique transferable skills to tackle colorectal metastases in difficult locations, and you can use hepatic ischemia techniques such as in situ, ex vivo, and anticitum. And of all segments of the liver, the caudate lobe poses particular challenges, and again, a transplant surgeon is best placed to operate in this area. Rapid is an evolving technique, and we'll have to wait and see what the trials and service evaluations show before we can make a decision on that. Thank you very much. Dhanyabad.
Excellent videos, sir. Any question from the audience?
Excellent videos as always, Dr. Menon. So I have two queries. One is with regards to that isolated caudate resections. So usually there is a big outflow vein just inferior to the MHV-LHV junction. So while doing it with the minimally accessed route, do you think there is any problem or any special trick to loop that vein without injuring the entry point of LHV, MHV common ostium? So it's usually a big outflow vein.
So if you have that outflow vein, what you can do is go from the top and not lift the left lateral up, go from the top, mobilize the left vein, go through Arancius ligament below, and then put a sling on the left vein so you have control to lift it up. And that traction gives you visualization, of that which vein. Then allows you to get to that difficult vein. In this one, it is a bit easier, but sometimes, as you say, and the second bit that can be difficult is if the caudate is going beneath the IVC onto the other side. Which really sometimes can pose a lot of a challenge.
Second question was with regards to the rapid. So in your experience or from literature, is there any evidence that the transplanted left lateral has developed metastases earlier than it's usually expected?
So we've not done any rapids. Paul Dagline has done, the world's biggest experience comes from Oslo, and they haven't had any, but they've had lung metastases, which has precluded them proceeding.
Just because of the local implantation or seeding of the tumor cells onto the graft.
No, they haven't seen that in their case series that they presented. But what they have seen is people not being able to progress to the next stage because of lung metastases while awaiting. So which is why I think the trick is to try and get into the second stage as soon as possible so that you can get the tumor burden off. That's what you're referring to.
Yes. And one last query is with regards to that ex situ excision. So I was wondering that we haven't done any, but since these patients don't have much of portal hypertension, is it possible that if you can limit your time, you can do it without a bypass?
Without the bypass. So I think the only reason for doing it with the bypass is gives you comfort. Less problems, the reperfusion bleeding, you're much more stable, your anesthetist is more happy. Because if you don't go on to bypass, and because there's no portal hypertension, you clamp the inflow and the outflow, you just get a lot of hemodynamic instability. So which means you'd then be very quick with your bench work of resecting the cava and the tumor.
And so it's only a portal bypass, or it also includes?
No, portal and systemic.
Only portal.
Full bypass. Full systemic. Axillofem and portal.
Oh.
Yeah.
If there are no questions, I would like to make one just comment that thank you very much for exactly coming up with a presentation which was what we thought and much more than what we thought. And I think that was a very, very valuable presentation and exactly customized to the topic, tailored to the topic. Thank you so much for this.
Thank you very much, Ramdeep. Thank you.